Good evening, dear students. Welcome to this session. And this is the message for you. I believe that the exam INI-CET went well according to the hard work which you have put, and we are expecting good results. The good news is eagerly awaited. But the purpose of this session today is to take care of some of the questions, which is kind of a recall. The questions which we have got is from you students only. So let us begin. The very first question which I have got is kind of a repeat question, if you believe. And this question is asking us about the function of the secretions which are coming from the arrow marked region. So it's a repeat question. You must have seen this earlier as well. In fact, I also taught it in the LRR for the NEET PG. So what do you think is the answer here? What exactly are we looking at? Here what you find is that it is a histology specimen, and which is, before you start looking at the diagram, you should look at the options, and you can find that there are some details of sexual function, maintenance of glucose level, or electrolyte balance, or the emergency response. So this comes something which relates with the adrenal gland. Now, if it is the histology section of the adrenal gland, then in the adrenal gland, we have the outer cortex, inner medulla. And in this diagram, we'll find that outside the adrenal gland will have the capsule. So where is this capsule in this diagram? If we locate the capsule, we'll find this is the capsule here, which is some collagen fibers. And then below that capsule, you can see this region is the cortex region. So that is the cortex region. And in the cortex region also, we understand that there will be a mnemonic GFR. So what are the three layers in the cortex that we can discuss? What do we mean by the G? That is the first layer. Then we have one F, which is the second layer, and then we will have the R, which is reticularis. In fact, before we start discussing the three layers of the cortex, let me show you one diagram that will be more clear. It is a section of the adrenal gland, histologic section, and as we understand, yes, Tatya, Bharti, it is GFR, and as we see, again we can repeat the information which we have just seen. The outer here, this region is basically the capsule, and from outside this region, that will be all the cortex. This region is going to be cortex, which will have three layers, and then below this will be the medulla, the inner medulla. Now, how do you identify various layers? First of all, you should know that the outermost is the G, as we have mentioned. So what is this G representing? This layer is the G, and then after that you have the R, GF, and then you have the R. How do you differentiate the three layers? You will see that the very first layer under the capsule is darker, then there is a lighter layer, and then again there is a darker layer. So alternate bands you can see. Under the capsule you have a darker area, then lighter area, then darker area. This is GFR, that is the cortex, and again you will find there is a lighter area, that is medulla oblongata. Now, once you have identified that this is the region below which we have the medulla oblongata, and that is the cortex, in the zona glomerulosa, you will have the cells which are arranged in glomerulus fashion, that is like renal glomerulus. You will see that they are in bunches. These cells are in bunches and glomerulus type of cells, and below that, if you look at the zona fasciculata, then there will be some fascicles of cells like this. And if you go still deeper, means towards the medulla, you'll have the reticularis. Reticularis means there'll be some network of cells. Reticular formation means network of cells, and the same thing can be seen here also, glomerulosa, fasciculata, and the reticularis. I'm not going into much details because we just want to have the idea that which question came, what could have been the answer. And then this is the medulla oblongata. Now we understand that medulla oblongata is giving us the epinephrine, norepinephrine, which is for emergency response like fight and flight reaction. And if it is about the zona glomerulosa, it is giving us mineralocorticoids like aldosterone. We understand that it is going to maintain the sodium, chlorine, and iron concentration in the urine. So that is the region where we are taking care of, that is the glomerulosa taking care of mineralocorticoids. And when it comes to the fasciculata, you have glucocorticoids, means hormones like cortisol, which are taking care of glucose metabolism. And then this the reticularis is having some weakly androgenic hormones like DHEA, which will give you some muscarinic effect basically. So with that overview, we can come back to our question, and you can see that the answer to this particular question should be. So it is asking the function of the secretions from the arrow mark region, means this region. So what is that? That is zona glomerulosa. And if it is zona glomerulosa, then it will be giving us mineralocorticoids like aldosterone. So that is why we are taking our answer as choice number C, electrolyte balance. Now, as we move on to the next question, it is showing us some diagram which is in fact taken from the developing bone, means growth plate basically. And what they are asking us is about the zone of calcification, where we have the zone of calcification. So before we answer whether it is ABCD, that is the markers put here, let us look at this diagram as well. As we are telling, this diagram has been taken from the developing bone. Like we have the developing bone where we'll have the shaft, the diaphysis, and the end, which is epiphysis, and between the two you will have this, what is called as the growth plate. So this is the region of the growth plate, and that growth plate is basically, most of the time it will be hyaline cartilage. The examiner has magnified that area of the growth plate, that is hyaline cartilage, and asking us about some zones like zone of calcification. Now when you magnify it, you will find, because it is hyaline cartilage, it will have some chondrocytes, and starting from the end or epiphysis towards the shaft diaphysis, you will find there is a zone of reserve cartilage, which is shown in schematic diagram as well as the actual histology diagram. There will be very small chondrocytes which are in resting stage. Then as you go towards the bone, means towards the diaphysis, you will find that these cells, they are undergoing proliferation. So there comes a zone of proliferation, which can be actually identified by the fact that the chondrocytes, which were simply lying like this, now they are proliferating. So they will make kind of rows, because one is, you can see here, one is getting 2 is getting 4. So these kind of rows can be seen. So that will be a zone of proliferation. And once you have zone of proliferation, there will be zone of hypertrophy, they become large. So as they are becoming larger, you will see the cell size is increased, and the one which you saw here in reserve zone, they have become quite large. And then after this zone of hypertrophy, which is large cells, they are entering a zone where you will have calcification. Now that calcification is brought by some of the blood vessels, they bring the calcium, and since there is calcification, this violet bluish color, because of that calcification, what happens is The chondrocytes, they depend upon diffusion for their nutrients and metabolism. But once there is calcification around the chondrocytes, the diffusion is not possible, they die. And as they are dying, there will be a zone of resorption, and calcification will change into the bone. So this is the zone of ossification. Here you see the bone. So bone of the diaphysis. Basically, this is the diaphysis, that is the growth plate, and this is the epiphysis, and diaphysis is growing. So the cartilage keeps turning into bone, 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 bone. Ultimately, all the growth plate will disappear and will become bone. So this is called endochondral ossification. Your job is, in this question, your job is to be able to identify various zones in the diagram. The resting zone, where the cartilage cells are small, and then you have zone of proliferation, zone of hypertrophy, zone of calcification, that was your answer, and then there will be zone of resorption and replaced by the bone. Once you have that idea, you can move further and you can choose your answer. So in this question, as we are asked for the zone of calcification, we understand that first there will be resting zone. This is the resting zone, and after resting zone we are having the, now here you see only 4 zones are given. So you start with resting zone, but then you should know that this appearance, what you have here is, you should be able to identify the bone actually. This is the zone of ossification. Now if that is the zone of ossification where the bone tissue is observed, bone tissue means you will have the, instead of chondrocytes, you will have osteocytes. And moreover, in the previous zone, when there was this zone of calcification, there will be dead chondrocytes. So before the bone, you will have the dead chondrocytes. That is where you have actually the zone of calcification. So this is the zone of calcification. You should be able to identify first the resting zone from upper end or one end, and the other end you should be identifying the bone. Now before the bone will have the chondrocytes, but they are dead chondrocytes because there is calcification. They cannot have now any glucose or any oxygen because diffusion is not happening in the zone of calcification. What will be before that? Before that, you see the cells are becoming quite large. They are quite large cells, and hypertrophy also. Now this could be zone of hypertrophy, or this could be zone of proliferation. It is merging basically. So zone of proliferation merging with zone of hypertrophy. The very first zone is zone which is resting zone. Then you'll have zone of proliferation. Then you'll have zone of hypertrophy. Then you'll have zone of calcification. Calcification can be identified by the fact now you will start having this dark blue, or you can say the violet color of this calcification can be seen, and bone appears totally different. So that is zone of ossification. That is why if you are asking for calcification, our answer should remain choice number C, and that is what I have marked. The answer to this question should be choice number C. Dr. Madan, okay sir. Yes, okay. Now as we move further, this is one question which has appeared. So what is it asking? This time the examiner has asked you, actually not this time, INI-CET people, they have this tendency of giving questions which appear simple but they are not simple, and if your basics are good, if you don't believe only in mugging up the answers, and if you really have worked upon your basics, then you will be able to reach the answer, otherwise it will be difficult. So what is the question asking? This question is asking which of the following joint type is not found in relation to the bone shown in the diagram. First of all, you have to identify which bone is this, and that bone is vertebra. So vertebra also, which vertebra? Is it cervical vertebra, thoracic, lumbar, or sacral or coccygeal? It is the body which is seen here, and then you have the articular facets, superior and inferior, and then you see the spine is quite long. And one more thing which you have to observe, and that is here, the articular facets. Now if you say these are the articular facets, they are costal facets for the ribs. A long spine and costal facets, it tells that it is the thoracic vertebra. Now if it is thoracic vertebra, fine. in the thoracic vertebra, which joint is not found? That is the question. Now, they are asking for syndesmosis, which is a fibrous joint. Syndesmosis is a fibrous joint. Then symphysis is secondary cartilaginous joint. And if it is plain synovial, we know freely mobile joint. Synchondrosis is primary cartilage joint. So, what should be our answer? Kumar Murjani says A. You are telling A for this particular question, the bone joint question? Yes, I think you are on the track, but not exactly that is the answer. So, if you talk about these bones, the vertebra bones, you will find that there are, let me just keep it on one side only. You will notice that these vertebra, this is one vertebra, another vertebra, the third vertebra, they are interconnected by what is called as the midline intervertebral joint, where you will have intervertebral disc. So, one vertebra articulating with other vertebra, and then there will be intervertebral disc between the vertebra. This is actually for shock absorption, and this is secondary cartilaginous joint. Now, if you say this is the secondary cartilaginous joint, it is symphysis. So, definitely these vertebra, the midline intervertebral joint is a symphysis, which is secondary cartilaginous joint. Now, that is about the joint which is between the vertebra. What about the joint which is between the superior articular facet, inferior articular facet? When you are talking about superior and inferior articular facet of the vertebra, there will be plain synovial joint, which are highly mobile. So, not only they have midline intervertebral joint, but they also have the articular facets also, they are articulating with the adjacent superior and inferior vertebra. So, there you will have plain synovial joint. They also have plain synovial joint when the ribs are coming and articulating. This question already came, the costotransverse joint and costovertebral joint. So, costovertebral with the body and costotransverse with the transverse process, even they are plain synovial joint. So, they definitely have plain synovial joint with the ribs and among each other also. Now, they also have syndesmosis. Syndesmosis means fibrous joint. How they have syndesmosis fibrous joint? You see, there are some ligaments which are connecting them. If you look at the spines, they are connected by supraspinous and interspinous. Now, the joint which you have where fibrous attachments are there to hold the bones, this will be qualifying as syndesmosis, fibrous joint. So, the supraspinous ligament, interspinous ligament, or ligamentum flavum, which is connecting the lamina of the adjacent bones, plus they will have the posterior longitudinal ligament, anterior longitudinal ligament. So, this is anterior longitudinal ligament, that is posterior longitudinal ligament. So, when you are connecting one vertebra with the other vertebra, the next vertebra with the help of these ligaments, this is called as syndesmosis. So, they also have syndesmosis or the fibrous joint, where some fibrous structures are holding the two bones with each other. Maybe anterior posterior longitudinal ligament, maybe the ligamentum flavum or the interspinous, supraspinous, they are all example of syndesmosis. So, what is left now? And that will be your answer. In this question, the examiner wanted you to mark your answer as, tell me. It is appearing that they do not have synchondrosis or what is called as primary cartilaginous joint. This vertebra is not having any primary cartilaginous joint, it has secondary cartilaginous joint, it has plain synovial joint and it has syndesmosis, but it does not have synchondrosis. Now, as we move on to the next question, it is a question which is asking us about the spinal sensory nucleus of trigeminal, and this spinal sensory nucleus of trigeminal is going to have second order neurons to carry which sensation? Now before you answer this question, let us look at the details, and the details you will find here. This is the diagram which will tell you about the details. You have to understand that the trigeminal nerve is having a ganglion which is trigeminal ganglion, and in the trigeminal ganglion you will have some neuron bodies, and those neuron bodies which we have here, they bring information from the face region, and then they are having first order neuron. So trigeminal ganglion is having the neuron bodies which is first order neuron, and they carry sensation from the face. Now from the face, most of the sensations they are received by trigeminal nerve, and the fibers they reach trigeminal ganglion, and then this is the receiving end, the sensation coming to the neuron body, and then this is the sending end or central process. That is peripheral process, this is central process. Now central process will go and synapse in the second order neuron. So where is the second order neuron? Second order neuron could be in the main sensory nucleus, or it could be in the spinal sensory nucleus. Trigeminal nerve has 3 nuclei, as you see. It will be having a spinal sensory nucleus, one the main sensory nucleus, and one which this is the chief sensory, and the one which is up there mesencephalic. So when we talk about the trigeminal nerve, it will have 3 nuclei. There is one spinal sensory nucleus. It is called spinal sensory because it is reaching the spinal cord, and then there is this main sensory which is actually in the pons. It will be in the pons of brainstem, and then there is mesencephalic sensory. Mesencephalic sensory is basically called so because it is in the midbrain. So in the midbrain we have mesencephalic sensory nucleus of trigeminal. In the pons we have the main sensory, and the spinal sensory is in the medulla oblongata, which is actually the brainstem now. This is what we will call as the brainstem. So in the brainstem we will have the midbrain, the pons and medulla oblongata, but then the spinal sensory not only is in the medulla oblongata, but it is also entering spinal cord, hence it is also called spinal sensory. So which kind of sensations they receive? That was the question. You have to understand that spinal sensory nucleus which passes medulla and enters the spinal cord, this nucleus is carrying pain and temperature from the face. It is carrying pain and temperature from the face. Then what is the main sensory nucleus receiving? It is basically, before you tell that what main sensory is receiving, you should know what the mesencephalic is receiving. So when you talk about the mesencephalic, it receives proprioception or position sense. So when you say proprioception or position sense of what? The structures which are there in the face, like you move your tongue, move your eyeball, move your jaw, like when you are eating. Why don't you bite your tongue? When we are eating, we don't bite our tongue because we know the position of our tongue. So that is called proprioception, and that proprioception position sense is received by mesencephalic sensory nucleus of trigeminal, which is of course in the midbrain. Whatever other sensations are there, they will be received by the main sensory, and that could be, as you can understand, vibration. The examiner has asked about vibration or touch. So touch, vibration, whatever. What I am telling you is, spinal sensory will have pain temperature from the face. The mesencephalic will have position sense. Whatever is left now will come to the main sensory. Its name is main sensory. Most of the information will reach here except for pain temperature and the vibration, the proprioception. Now, once you have this information, you understand that whatever you brought, pain, temperature or position or the vibration, touch, all come to the trigeminal ganglion, but proprioception is different. Now when you say proprioception is different, how the proprioception is different, let me show you the detail here. The proprioception sense will come, it will bypass the trigeminal ganglion without synapsing, and the first order neuron will be in the mesencephalic sensory nucleus of trigeminal. So this is one difference, that the mesencephalic sensory nucleus of trigeminal, the neuron body is first order neuron, and it was directly receiving proprioception. And then this was the peripheral process. Central process will go and synapse in the motor nucleus of trigeminal, which will control the movement of muscles, basically movement of the jaw muscles of mastication. So what is the purpose of having this pathway? This is the pathway which works for jaw jerk also. You do the jaw jerk and this pathway gets activated. When you are talking about the position sense of the jaw, the trigeminal nerve will take the information. That information bypasses the trigeminal ganglion. It does not synapse there. And the first order neuron will be in the mesencephalic sensory nucleus of trigeminal. And then this was the peripheral process. The central process will go to the motor nucleus of trigeminal, which is again in the pons, and that will control the muscles of mastication, which can move the jaw. That is why when we are having food and we are not biting our tongue, it is because we know what is the position of our tongue and our jaw, and there is a reflex. The chief purpose of this discussion is, when you talk about the other nuclei, main sensory or the spinal sensory, they'll have second order neuron, because first order neuron will be in the trigeminal ganglion. And then if you talk about the mesencephalic sensory, it will have first order neuron, because as such it is sending the central process without any synapse in the trigeminal ganglion. So this information might help you. But if you were, this was a simple question as such. So if you are asking for the answer, question was asking spinal sensory nucleus of trigeminal, then it has second order neuron definitely. And then which sensation it carry? It is pain and temperature. That is your answer. Touch is received by main sensory. And if you are talking about vibration, main sensory. If you are talking about proprioception, it is mesencephalic sensory. And if you say it is mesencephalic sensory, then it was having one special feature. It had first order neuron. It had first order neuron. And one more question can come. Mesencephalic sensory nucleus of trigeminal has unipolar neurons. It is unipolar. Normally, the sensory neurons are pseudo-unipolar. Other nuclei of trigeminal, they'll have pseudo-unipolar neurons in the trigeminal ganglion. But mesencephalic sensory nucleus of trigeminal is special due to many reasons. One, it is not having second order neuron, it is having first order neuron. The other point, it is unipolar in character. And then there are some other findings also, but here we will keep our answer as choice number B. Zone of calcification, Manik is asking, zone of calcification isn't D. You have to understand one thing here when you are looking at this diagram. Your eyes must be trained. Train your eyes for identifying the chondrocytes, small chondrocytes, larger chondrocytes, making rows, and then it is becoming hypertrophied. You see, there is a change of color here, and as there is change of color, it is calcification. Bone is eosinophilic, and this calcification is hematoxylin, more of hematoxylin. You will see that where you have calcification, you'll have more of hematoxylin, blue color, and bone will have more of pinkish color. This is osseoid tissue. Your eyes must be able to identify how the bone looks, how the chondrocytes and the osteocytes look. This is bone tissue. Now, if you say this is bone tissue, then this is the zone of ossification. And prior to that, maybe in this diagram you are unable to decipher. That is why I wonder that in the exam when you are given those slides, is it really possible to detect all those findings within a minute and answer also? But anyway, if this was first time, you may be making mistakes. Repeat questions, you should not make mistakes. But this is zone of ossification. That is zone of calcification. That is zone of proliferation and dying cells. So dying cells means they will be hypertrophying, and then they will be dead also. But dead cells will be in the zone of calcification. Here you will not find Actually, the lacuna, chondrocytes, all the means I am not going to details. If you are asking me, this is bone, zone of ossification, this is zone of calcification, otherwise it is a long discussion. So, Manik, zone of ossification is, you are asking zone of calcification is in D. No, D is zone of ossification. Zone of calcification is zone C. Okay, so as we proceed further, you find this question which you must be knowing the answer. It is asking about the substantia nigra, which we know is in the midbrain. So, substantia nigra, which is in the midbrain and is connected to which part of the basal ganglia. So, basal ganglia, as continuously we keep getting questions upon, before you look at the, try to find the answer, look at this circuitry of basal ganglia. In the circuitry of basal ganglia, we understand that we have to start with a thought will come, and that thought will be coming in the neocortex. Now, if it is in the neocortex, the thought will come towards the striatum, and from the striatum it will go to the globus pallidus, and from the globus pallidus it will go towards the thalamus, and from the thalamus it will come back to the neocortex. It is for planning and programming of the movement before you actually do the movement. And how do you do the movement? For the movement, now the cortex will tell pyramidal tract to the brainstem spinal cord, and the movement will happen. But before the movement happens by pyramidal tract, you must plan it and program it. So, first, say for example, there is a thread and needle. I want to put the thread into needle, but before I put the thread into needle, I must plan. The thread should be in my right hand, needle should be in my left hand, and then I have to do this. This is, I am doing nothing, I am just planning. That planning is done by basal ganglia, and once I do it, that is done by pyramidal system. This is pyramidal system which will actually do the movement, and this is extrapyramidal system which will plan the movement. So, first I will have the thought, I have to put thread into needle. That thought will come in the cortex. Cortex will tell that to striatum. Striatum will tell that to globus pallidus. Globus pallidus will tell that to the relay center, which is thalamus, and thalamus will tell it back to the cortex. Okay, planned. Now planned, do it. And then this was extrapyramidal system. Then the pyramidal system will work and you will do the actual movement. Now, what is the role of substantia nigra here? The role of substantia nigra, as you will notice, is that substantia nigra does not come in this pathway. It is just influencing the striatum. This is called as nigrostriatal pathway. So, this is the nigrostriatal pathway. Substantia nigra going to striatum, and that is what the examiner is asking. You know, if it is compromised, you can have Parkinson's disease. So, nigrostriatal pathway, if it is compromised, you can have Parkinson's disease, and then what happens is you will have purposeless involuntary movements. And one of that purposeless involuntary movement in Parkinson's is pill rolling tremor. So, as such, substantia nigra is not coming in these pathway, but it has influence. Substantia nigra will make dopamine, and that dopamine affects the striatum. If somehow you have less of dopamine, this nigrostriatal pathway is compromised. Deficiency of dopamine results in Parkinson's disease, and there will be some purposeless involuntary movements like pill rolling tremor. So, that is the role of the substantia nigra. And then there are other components also, like subthalamic nucleus. If it is compromised, there can be hemiballismus, but again, it is not coming in direct pathway. It is in between. So, again, not going to details. We just want to look at the questions. We just want to have the answers. And as you can see, we have got our answer. It is asking substantia nigra, nigrostriatal pathway. So, nigrostriatal pathway means it is striatum. As you know, basal ganglia will have the caudate nucleus, it will have the putamen, and it will have the globus pallidus. So, pallidum means it is globus pallidus. And if it is caudoputamen, then you are calling it as the striatum. This is what we call as the striatum. This is striatum. Caudate plus putamen. So our answer should remain choice number A here. Okay, so it was image based, as TM is telling. It was not histology slide. Some students told that it was histology slide. This zone of calcification and all that, it was histology slide, some students told, and the TM is telling it was image based. Image means what? Schematic diagram, or was it histology slide? Okay, then it was image based question. Dentado-thalamic tract was asked. Cross section of cerebellum, that is a different question. That is a different question. Or was it this same question, substantia nigra? It was image based. This question I have got. Yeah, so I think you are talking about another question, and that maybe this question, but it was not in this format, it was in other format. Maybe it was like this. There was a diagram of cerebellum given, and in cerebellum they have shown the dentate nucleus, and they are asking from the dentate nucleus of cerebellum. Then in the center you were, because of course this cerebellum is around the brainstem. So in the center there was this brainstem also, it was a midbrain, and in the midbrain also, you know, there is this crus cerebri and aqueduct, and then there was this red nucleus. Maybe some students have told something like that. So it was a cut section of cerebellum, transverse section, and the dentate nucleus was marked, and then in the center, which I have taken out and magnified, it was the midbrain. In the midbrain, this was the aqueduct of Sylvius, that is the red nucleus. So maybe, as you are telling, they were asking about dentato-rubro-thalamic tract. Dentato-rubro, and then it goes to thalamic tract. So from the dentate nucleus, some fibers will go to the red nucleus, and from the red nucleus they'll go to the thalamus. Maybe that was the question then. Two different sections given. So one section here, maybe that is how it was. So this, I believe this is a different question, and the question which I am discussing is different, but anyway, we have discussed both of them. Now, as we look at this one, this question is asking us about the structure which is not present in the floor of the inferior horn of lateral ventricle. Let me tell you one thing here. Normally what we say is, what I don't say means, normally most of the faculty will say, do the last 5-year questions and you are ready. I don't say that. I say, do your 5-year questions, then go beyond that. Do your 10-year questions, go beyond 15-year questions. All these questions which you are seeing, they are not new questions, they are all repeat questions and AIMS questions actually. So a question which came 15 years back has appeared again. That is why the normally we want shortcuts, ultra shortcuts, but at some point of time we will be stuck and we will suffer the consequences, and that is what. So because the examiner is not asking last 5-year, 10-year any lateral ventricle, so we are not bothered, we don't teach, and because we don't teach, you think that it is not important. So, and this happens. So that is why making your content concise, but how much concise can you make it? So this is, if somebody tells me that this is a new question, I am very sorry, it is not a new question, it is a repeat question. But how will I justify? because I have seen this system for last 23 years. 23 years. But the problem is these days we people are old school and some new generation has come. They have their own ways and they have kind of mesmerized the audience, and people really don't believe what we say, the old school people, and we also keep mum. We don't talk much. We just do whatever we think is good for the benefit of students. But it is sad. We feel sad. This world of this new generation short, ultra short and ultra short things, that is not how you become a good doctor. So 15 years, last 15 years question, revising last 15 years question is not a big deal. You are deciding your life. You want to do PG in medicine or surgery or OBG, you are deciding for your life, and how can you just depend upon somebody who is revising your, first of all, a single person revising all the 19 subjects, and that also in 2 days, 3 days. But okay, I'll say nothing. Yeah, Sagar, good evening. Bad quality images. That is a tragedy in India. What to do? We have examination system in place, but we do not have the quality. Anyway, there is no use of cribbing. We are just wasting our time. So, what do you think about this? Lateral ventricle. So, normally we don't talk about lateral ventricle. Generally, we talk about third ventricle, fourth ventricle, because the repeated questions are coming. But now questions are coming on lateral ventricle. You will see us start teaching lateral ventricle from the next session. So, that's what we do. But and why we do that? Because you don't have the patience, you don't have the time. You want the things to be done in some 15-20 hours, do all the anatomy. How is that possible? And then you suffer the consequences. Anyway, this is lateral ventricle, which is C-shaped ventricle, as the brain became C-shaped, and I teach all that in the main videos. Actually, main videos we try to cover as much as possible. So, lateral ventricle is a C-shaped ventricle. It will have one frontal horn, which is in the frontal lobe, one posterior horn, which is in the occipital lobe, and one inferior horn, which is in the temporal lobe. They are asking about inferior horn. Inferior horn means temporal horn. So, temporal horn also will have the roof and the floor. You know, these ventricles, they are filled with CSF. So, they are filled with CSF. They are asking what is not at the floor of the inferior horn of the lateral ventricle. For that purpose, we have taken a transverse, it's a coronal section from the front view, and as you take this coronal section, we have magnified also. This is what they are asking. This is the inferior horn of the lateral ventricle, and it is in the temporal lobe. So, if that is the region, we have magnified it, and that magnification is there. Now, as we are telling, it's a ventricle, and ventricle is filled with CSF. So, inferior horn of lateral ventricle, and it is filled with CSF. What is not at the floor? Now, first we should know what is at the floor. So, as you are talking about some structures which are at the floor, one is hippocampus. So, hippocampus, as we know, is in the inferior temporal lobe, and it is lying at the floor of the lateral ventricle, inferior horn. So, it is there. Then you have the hippocampus giving you fornix, and as the hippocampus gives the fornix, a part of fornix is seen here, fimbria. So, even the part of fornix, because you know hippocampus sends the major output tract is fornix, and fornix will have certain components. One is fimbria. So, fimbria is also at the floor. What else is at the floor? You know, this is occipital visual cortex, and the occipital visual cortex will have a calcarine sulcus, and that calcarine sulcus is producing an elevation in the floor of the lateral ventricle, inferior horn, and that calcarine, not calcarine, it is the collateral sulcus. So, that collateral sulcus is producing the elevation which is called calcar avis. So this is the collateral eminence. So there is a calcar avus, there is a collateral eminence, there is this fimbria. All these are at the floor of the, or simply you may be thinking that he has started teaching us the crude neuroanatomy here. So maybe we can go the other way around, the rule of exception. And what you find is that the tail of caudate nucleus is not at the floor, it is at the roof, along with stria terminalis. So tail of caudate nucleus, stria terminalis, we don't teach such things normally. These things are taught in the first year undergraduate level, and the examiner somehow he just want to assert himself that don't think you will escape your means, normally what the first year student will do. First year student will just try to manage and pass. And if he knows that no such questions are asked in PG entrance, then he will be totally unbothered. So these type of questions the examiner is putting to make sure that students don't take first year lightly. We teach all these things in first year in detail, but we don't expect you to remember everything. It is not possible. So what should I remember? At least you have to practice previous year questions. And as I told you, these questions are not new questions, they are repeat questions. Only I will know that, because I don't think anybody in the system is old enough to realize that it is a repeat question. Nobody. There is nobody of my age of such experience. Anyway, it's maybe it's an advice for the students who are preparing for the next exams like NEET PG. You should be careful. Do the last 15-year questions. That is the advice. I start my lecture with that only. Do 5 years, 10 years and 15 years. Don't be casual in approach, and your basics should be good. You cannot handle such questions without just by cramming some things. So why not the tail? Because it is at the roof, not at the floor. Hippocampus is there, fimbria is the part of fornix, and collateral eminence, as we said, there is a collateral sulcus, produces an elevation, and all that, which is the crude anatomy. This is totally crude anatomy, but some things we have to remember. अच्छा सर, आपने पढ़ाया उसमें से कुछ नहीं आया. क्या नाम है? सेल्फी एम्प्रूवर है ना, डॉक्टर सेल्फी एम्प्रूवर. ये बताओ कि कहाँ क्या सोर्स था तुम्हारा पढ़ने का? मैंने नहीं पढ़ाया, ठीक है, और मैंने पढ़ाया उसमें से कुछ नहीं आया, ये आप कह रहे हो. सोर्स क्या तुम्हारा पढ़ने का? बताओ, यहां लिखो. अगर तुमने मेरे मेन वीडियो करे होते ना तो 80% आंसर्स तुम्हारे को होते, यू कुड हैव डन. और सिर्फ मेन वीडियोस ही नहीं, उसके बाद जो ये हम LRR करते हैं वो भी करना ज़रूरी होता है. ये एक किस्म का LRR ही है, लास्ट रिजॉर्ट रिवीजन ही है. ये जो अभी नीट PG आ रहा है, ये सब आपको देखते रहना चाहिए. तो ये जो आप लिख रहे हो यहाँ पर, डॉक्टर सेल्फ इम्प्रूवर, सेल्फ आई एम प्रूवर, वट, ये तो बताओ कि पढ़ा कहाँ से है. अगर तुम ये सोच रहे हो कि LRR को ही देखकर, LRR को भी देखा था अगर तुमने, तो मैंने कहा था. वैसे हमारी बातें कोई सुनता नहीं है तो बोलने का फायदा नहीं. मगर अगर मेरी मेन वीडियोस आपने करे होते तो 80% क्वेश्चंस आए हुए उसमें से. पर ये नहीं है कि डायरेक्ट आए हुए, मैंने बोला और वहां से आंसर लगे. इससे यही तो INI-CET की खासियत क्या है, आपको अपना भी दिमाग लगाना पड़ेगा आंसर्स तक पहुंचने के लिए. और इसीलिए मैं आपको चीजें रटाता नहीं हूं, इसलिए चीजें समझाता हूं, ताकि आप अपना दिमाग लगाने की आप में ताकत बाकी रहे. एक तरीका होता है कि पित कर दो फ्रॉक को, ऐसे पड़ा हुआ है, कुछ नहीं कर सकता, वो नहीं करता. मैं स्टिमुलेट करता हूं माइंड को सोचने के लिए. एनीवे, सो अगर आपने मेरे मेन वीडियोस करे हुए हैं तो आपको आंसर आ जाना चाहिए, मगर ये हमने LRR में तो नहीं पढ़ाया। अभी जो ये कह रहा था, जो भी स्टूडेंट था, चलो खैर छोड़ो, इतना सब करने के बाद यही सुनने को मिलेगा और क्या। ये नहीं पता कि अपनी गलती क्या है, दूसरे के ऊपर इल्जाम लगाना बहुत आसान होता है। So this is one question which is I think it was diagram based, and then it is asking which of the following structure passes through the arrow marked region. Basically there is a superior pharyngeal constrictor, there is a middle pharyngeal constrictor, and then inferior pharyngeal constrictor, and the arrow mark is between superior and middle pharyngeal constrictor. Actually one muscle is also shown, but these are color diagrams. Maybe what you got was a schematic diagram, maybe what you got was a dissected specimen, but the student, they were telling that we were able to see that there are 3 pharyngeal constrictor, and they were asking the structures which are passing between superior and middle pharyngeal constrictor. Now before we answer the question, you see this is what we teach in our main videos. It's a coronal section from the front view, coronal section from the front view, and you have the base of skull, then you have superior pharyngeal constrictor, middle and inferior pharyngeal constrictor. There are gaps in between and some structures pass through that. So looking from the front view, you can see this is the base of the skull, and then you can see that these are the muscles we are talking about. Superior pharyngeal constrictor, then you have the middle pharyngeal constrictor, and then you have the inferior pharyngeal constrictor. Now as you can see, there are some structures which are passing between the superior and middle pharyngeal constrictor, and that is the muscle of third arch, nerve of third arch. So which is the muscle of third arch and which is the nerve of third arch? As we know, the muscle of the third arch is stylopharyngeus muscle, and the nerve of third arch is glossopharyngeal nerve. So glossopharyngeal nerve, stylopharyngeus muscle, they are passing through this region, and that was your question. There are other details also, but then this session is not to teach you other things. This session is just to make sure that which question came and what is the answer, what is the perfect answer. So as you can see, the answer is the structures which belong to the third pharyngeal arch, that is glossopharyngeal nerve and the stylopharyngeus muscle. Now if you say that I have, जैसे कहा उस बच्चे ने कहा कि आपने जो पढ़ाया उसमें से कुछ नहीं आया, तो मैंने तो ये भी पढ़ाया था, क्या आपने पढ़ा था उसको? इसमें गलती किसकी है, मेरी आपकी? अगर कोई एनाटॉमी 3-4 घंटे में खत्म होने वाली होती तो हम उसे 100 घंटे का वीडियो क्यों बनाया होता? हमने 100 घंटे का वीडियो है, मेरे प्रेपलैडर में है 100 घंटे के वीडियो है, तो 100 घंटे का वीडियो क्यों बनाया हुआ? और मुझे लगता है अभी भी कम है, मैं उसको 120 घंटे करने की कोशिश कर रहा हूं। क्यों? अगर 3-4 घंटे में ही खत्म हो सकती होती है एनाटॉमी तो मैं भी कर देता, मुझे भी इतनी मेहनत करने की क्या जरूरत है? मगर ऐसे खत्म नहीं होती। और एग्जामिनर बहुत स्मार्ट है, वो कब तुम्हारी ऐसी तैसी फेर देगा पता भी नहीं चलेगा, वो मुझे पता है। और इसलिए जो एडवाइस है ना आपके लिए, वो एडवाइस ये है कि बी केयरफुल। So this is your answer, and now एक तो मुझे ये समझ में नहीं आता कि एग्जाम कल हुआ और हमें कहते हैं कि एक दिन है आपके पास और आप क्वेश्चन भी ले लो, आंसर भी ले लो, सब तैयारी कर लो, मतलब समय भी नहीं दिया जाता है। अब मेरी तैयारी नहीं थी, बीच में हम मैं आ गया उठ के, एंड अब क्या करें, ये लो बाकी क्वेश्चन अब इस फॉर्मेट में लो, क्योंकि जब मुझे समय नहीं दिया जाएगा काम करने के लिए तो क्या होगा, यही होगा जो आपकी आंखों के सामने अब आप देख रहे हो. Anyway, I have not prepared slides for this, and we are just trying to manage now. So this question is asking cross section at which level. So tell me what is your answer. हाँ जी, चैट में भी पढ़ लेते हैं क्या है. चलो कुछ बच्चे तो कम से कम समझते हैं कि मैं क्या करने की कोशिश कर रहा हूँ. मैं सिर्फ एक कोशिश कर रहा हूँ कि आप अच्छे डॉक्टर बने, उसके अलावा मेरा कोई और पर्पज़ नहीं है. ये एक बैरियर है कि पीजी आपने निकालना है, वो भी हो जाएगा, पर मेरा पर्पज़ आपको पीजी निकालने में हेल्प करना नहीं है. मेरा पर्पज़ ये है कि आप एक अच्छे डॉक्टर बने, आपको अच्छी नॉलेज दी जाए, और ये पीजी एंट्रेंस तो आप कर ही लोगे, हो जाएगा. उससे आगे मेरी सोच आगे है. Right. So and students are telling it is T12. Why would you say it is T12? Why would you say it is T12? T12 ईसोफेगस नहीं है. ओके, ईसोफेगस नहीं है तो 10 से नीचे ही होगा. Esophagus crosses the diaphragm at T10 level. ओके, अच्छा दिमाग लगाया आपने, मगर ईसोफेगस तो नजर आ रहा है मुझे. मुझे तो ईसोफेगस नजर आ रहा है. ये क्या है, मैं इसको बड़ा कर देता हूं. ये क्या चीज है, ये इसको थोड़ा सा बड़ा कर देता हूं. ये क्या चीज है, ये ईसोफेगस ही तो है. अच्छा, इमेज में ईसोफेगस नहीं था. अच्छा जी, मगर मेरे ख्याल से इमेज यही थी. मैं आपको उसका रीजंस बताता हूं. पहले तो इसमें डिसाइड करते क्या किया. देखो, ये है स्पाइनल कॉर्ड, यहाँ पर ये स्पाइनल कॉर्ड है, ये लंग्स आ रहे हैं, ये राइट लंग है, ये लेफ्ट लंग है, ठीक है. और साथ में आपको स्प्लीन भी दिखाई दे रही है. यू कैन सी द स्प्लीन ऑल्सो. दिस इज पार्ट ऑफ द स्प्लीन. एंड देन यू कैन सी द स्टमक. देन यू कैन सी द लीवर. दिस इज लीवर. एंड दिस इज inferior vena cava. Inferior vena cava, and that is aorta. That is the aorta. So this is the spinal cord in the vertebral canal posteriorly. That is the right lung, left lung, and this is the aorta to the left side of midline. That is inferior vena cava, posterior to the liver, and this is the esophagus. That is the stomach. This is the spleen. Spleen has just appeared. Spleen has just appeared. Lungs are still there. You know, lungs posteriorly can be at T10 vertebra level. T10. So what I understand is that you are at T10 vertebral level. This diagram is, this section is at T10 level because you can see the lungs. If you go at T11, T12 level, you will not see the lungs. That is the only thing which I thought. We didn't see the lung tissue much. Okay, even if you didn't see the lung tissue too much, say lungs, what is the inferior marking? Mid clavicle line 8, mid axillary line 10, that is the 6, 8 and 10. So 10th rib or 10th vertebra. Even if it was expiration, it can reach 11. But if you see lung tissue, the point is, though you are telling diagram was different, lungs were not there. Lungs were not there. Are you sure that lungs were not there? Because I have several sections. I have section at T9, 10, 11, 12 because they were the options which you are having. I have gone through various sections. You are telling lungs are not there, and then diagram was different, but then Sonali is telling same image, only aorta was visible, it was there, the same image was put. So that means part spleen seen evidently. So that means falciform ligament is seen in the cut section, esophagus nahi tha. That means it is a controversial question, and that means you should train yourself now, because we will have to make some discussion now. What do you find at T9 level or T10, 11, T11 level, T12 or L1? Normally we teach L1. In my class I teach transpyloric plane, L1. But since you yourself are not convinced whether the lung was there or not there, and whether the spleen was there, whether the esophagus was not there, but if you ask me, this level, this is T10 level. And why it is T10 level? Because I still see the lung. If you don't see the lung, it is T11 forward. If you say T12, let us say if it is T12, T12 is reaching almost transpyloric plane. In that sense, you will have some colon also. Were you having colon also? If it was T12, did you have colon also? So I think this way we cannot actually reach a consensus. My job will be to discuss the levels at T9, 10, 11, 12 separately and compare, and points which you are giving are correct. There is no doubt. But then we don't know exactly what was the question. If this was the question, if this was the image, it is T10. But I agree, maybe they could have given some other section, but if this was the section, then for this particular section I will take my answer as T10. Here I will take my answer as T10, and then we can plan some session where we can have more of a discussion. Now this is a question asking which artery is supplying the following part of the heart. So which part of the heart they are marking? As you see, it is the cut section of the heart, and mostly I think interventricular septum. That is what they are asking, interventricular septum. So is that the same question? नेटर में T12 के जैसा इमेज है, मोस्टली वो इमेज नहीं, ऐसा नहीं है. मैं आपको मालूम है मेरे पास चैट जीपीटी ओ है. चैट जीपीटी ओ से मैंने 1.5 घंटा यही बात करी है. चैट जीपीटी ओ में मैंने सारे डायग्राम डाल दिए और उससे मैंने पूछा कौन से लेवल पे है. उससे मैं 1.5 घंटा मैंने आज उससे बात करी है, और बाद में पता चला कि उसको भी कुछ नहीं आता. ऑब्वियसली उसको वही आता होगा जो हम सिखाएंगे. तो ये जो है बड़ी कंट्रोवर्शियल टॉपिक्स हैं, और मैं तो किसी भी लेवल तक जाता हूँ. जिस लेवल पे मैं चला जाता हूँ वहाँ तो पहुँचना, जहाँ ना पहुँचे रवि वहाँ पहुँचे कवि. कि जहाँ पे सूरज नहीं पहुँचता वहाँ पर कवि पहुँच जाता है, मतलब पोएट पहुँच जाता है. और आई एम दैट काइंड ऑफ अ पर्सन. सूरज जहाँ ना पहुँचता होगा मैं वहाँ भी पहुँच जाऊँगा अगर मुझे कहीं पे कुछ कन्फ्यूजन मिल रहा है. पर वो मेरा काम है, आपका काम नहीं है. अभी नहीं करना आपको वो. जब आप प्रोफेशन में कामयाब हो जाएंगे, 10-20 साल हो जाएंगे, उसके बाद 21वें साल ऐसी हरकतें करना. अभी तो जल्दी जल्दी से निपटाओ जो निपट सकता है. एनीवे, मॉडरेटर बैंड वाज विजिबल. ओके, चैट जीपीटी को नहीं आया तो नहीं हो. चैट जीपीटी पता कौन सा वाला, लेटेस्ट वाला चैट जीपीटी ओ, जो कि हो सकता है हिंदुस्तान में 4-5 लोगों के पास ही है इस वक्त. उनमें से एक मैं हूं. मेरा काम ही यही है, मैं करता ही यही हूँ. 90% मेरी लाइफ यही है. 90% ऑफ माई टाइम इज फॉर एनाटॉमी एंड यू पीपल. उसके बाद कोई आके कहे सर आपने पढ़ाया उसमें से नहीं आया, तो बड़े दुख की बात है, क्योंकि ये हकीकत भी नहीं है। एक तो है हकीकत हो तो चलो फिर तो बहुत ही ज़्यादा दुख की बात हो गई, मगर दुख की बात यह है कि पढ़ा भी रहे हैं उसके बाद इल्ज़ाम लगता है कि आप पढ़ाते नहीं हो, आप उसमें से आता नहीं है कैसे। अगेन ये जो डायग्राम है, अगर आपने मेरे मेन वीडियो करे हैं और मेन वीडियो में अगर आर्टीरियल सप्लाई करी है, कोई मुझे कह दे एक बार कि मेरे को आंसर नहीं मिलता, मतलब बड़े दुख की बात होगी। मगर मुझे ये बताओ कि क्वेश्चन ये था कि नहीं था? शायरी सुबह होती है शाम होती है, उम्र यूं ही तमाम होती है, एनाटॉमी में मेरी। Okay, if this was the question, then let me zoom, and this is interventricular septum. Anterior 2/3 of interventricular septum or major part of interventricular septum is supplied by anterior interventricular artery. So that is what I think the examiner was actually trying to ask. If this was the question, then we know what should be our answer. Our answer for this particular question should be anterior interventricular artery, because it will supply anterior 2/3 of interventricular septum or major part of interventricular septum. If you talk about right coronary artery, it will give posterior interventricular artery, and posterior interventricular artery will supply posterior 1/3 of interventricular septum. So if you go more posterior, then it is posterior interventricular artery, which is a branch of right coronary artery, and that will be supplying posterior part of interventricular septum. Anterior interventricular artery is a branch of left coronary artery. So left coronary artery give an AIVA, and which will supply anterior 2/3 of interventricular septum. I believe that the examiner wanted this answer. That is your answer. Chordae tendinae, yeah, chordae tendinae, these are chordae tendinae only. If you are talking about chordae tendinae, these are all chordae tendinae only. Tendinous cords, they are holding the septum like tricuspid valve. The valves are held by chordae tendinae. There the chordae tendinae will be holding the mitral valve. So these are all chordae tendinae only. Septum is marked. Diagonal artery was there in the option. Diagonal artery will not supply interventricular septum as such. Diagonal artery will not supply interventricular septum. अगर आपने LRR किया था तो LRR में हमने डिस्कस किया हुआ है, पर अगेन ये क्लास इस पर्पज से नहीं है कि मैं काफ़ी डिटेल में चला जाऊँ. What we just want is, I just want to have an idea what kind of questions were there, and we just want to have one answer, and then we can explore it further, so that we can prepare you for the next coming exam, which is NEET PG. Now this is one question which I believe that radiology people are also teaching. So as we magnify, you should know that this is a chest X-ray taken from PA view, posterior anterior view, because vertebral column is prominent, and attaching to that vertebral column will be the ribs. So these are the ribs which are attaching to the vertebral column, and they are posteriorly. So posteriorly the ribs will become more prominent, and they will be almost running horizontal, but then they have to go anterior, and somehow the arrow mark was at such a point that students are telling we were unable to find whether they are asking for posterior part of rib or anterior part of rib. Now it depends, this arrow, if it goes here, posterior, otherwise it will be anterior. So how will you know the anterior? Now I have zoomed it so much that maybe you are unable to see the details, but then I can mark the anterior end also. Now the same rib will go and come anteriorly, but anteriorly the costal cartilage is not evident. So the same ribs, when they go posterior, means I can show it on the other side. If these are the posterior ends, then what about the anterior end? Anteriorly, you will see these markings are anterior. So ribs go anterior and suddenly they disappear actually. Suddenly they'll disappearing. Why? Because the costal cartilage do not appear on X-rays. So anterior part of the rib suddenly disappears. Costal cartilage is not coming in the X-ray. But if the rib is totally reaching the midline, totally reaching the vertebra, then it is posterior part. So posterior part of rib is first of all horizontal, anterior are more oblique, posterior horizontal, anterior are more oblique. Posterior is reaching the midline, attaching to the vertebra. Anterior, they don't actually, they come and suddenly disappear because costal cartilage will not be prominently evident, or it is not evident in X-ray at least. But again the problem is, was this anterior end or was it the posterior end? I think it was anterior end because arrow was not on the posterior, it was on the anterior shadow. So it depends. Now again the story is डिपेंड्स कहाँ एरो है, एरो के ऊपर डिपेंड कर रहा है. ये एरो तो मुझे एंटीरियर एंड पे लग रहा है. इसको थोड़ा सा और जूम कर लेते हैं. ये असल में क्या है कि जो सॉफ्टवेयर मैं यूज़ करता हूँ वो थोड़ा अलग होता है. ये यहाँ पे मैं आपको दिखा रहा हूँ, जो चीज़ दिखाना चाह रहा हूँ वो ये है. ये देखो ये है, तो वो एरो जो है वो एंटीरियर के ऊपर है. अब वो एरो को थोड़ा सा इधर कर दो तो पोस्टीरियर के ऊपर हो जाएगा. बड़े ही दुविधा की बात है, पर इस वक्त तो मेरा आंसर एंटीरियर ही है. और हो सकता है कि ये डायग्राम ना हो आपके पास डायग्राम कोई और हो एग्जाम में और आपने सही आंसर लगाया हो. ऐसा मत सोचिए कि मेरे पास वही डायग्राम है जो एग्जामिनर ने दिया था, तो हो सकता है एग्जामिनर ने कुछ और डायग्राम दिया हो और आपका आंसर सही हो. मेरा मकसद ये नहीं कि आपको बताना कि आप गलत आंसर लगा के आए हो, ये तो मैं कभी करता ही नहीं. मेरा एक ही काम है, हौसला बढ़ाना, आपका उत्साह बढ़ाना. हौसला कम करना मेरा कभी इरादा नहीं होता. आई एम वेरी पॉजिटिव पर्सन. आई डोंट टॉक नेगेटिव एंड आई move away from anything which is negative, which you should also do. You should stay positive all the time. You should have positive toxicity. People say you have negative toxicity. I have positive toxicity. I'm so positive that negative things do not influence me for long. And that is how you should be. Now, what about this question? एब्डोमेन के सेक्शन में स्प्लीन इज विजिबल. या एब्डोमेन के सेक्शन में स्प्लीन अगर विजिबल है तो T10 लेवल पे स्प्लीन आ जाती है. स्प्लीन जो है वो 9, 10, 11 रिब के साथ होती है, और स्प्लीन अगर 9, 10, 11 रिब के साथ है तो T10 लेवल पे थोड़ी सी स्प्लीन दिखती है. इस डायग्राम में भी अगर आप देखो, इस डायग्राम में हमने क्या देखा था, इस डायग्राम में हमारे पास थोड़ी सी, नहीं यहाँ पे था कि वहाँ पे था, यहाँ तो वहीं पे था. ये आप यहाँ देख रहे हो ना, ये स्प्लीन तो है, ये स्प्लीन ही है, ये स्प्लीन है. यही तो मैं चैट जीपीटी से पूछ रहा था. चैट जीपीटी 4 से नहीं, चैट जीपीटी ओ जो है अभी नया आया है, ओमनी. ये स्प्लीन ही तो है. इसको मैं मिटा देता हूँ, आप देखो, ये स्प्लीन है, ये स्प्लीन है. This is spleen. So part of the spleen has come along with the stomach, and that is why I am telling it is T10 level. थोड़ी सी और बड़ी हो जाएगी तो T लेवल हो जाएगा, और बहुत बड़ी हो जाएगी तो T12 हो जाएगा. तब तक तो खत्म भी हो जाएगी. T12 तक आते आते तो स्प्लीन मतलब एंड होने पे आ जाती है. सो देयर आर लॉट ऑफ थिंग्स. ये तो मैं सोच रहा था कि एग्जामिनर ऐसे क्वेश्चन, क्या आपको ऐसे पढ़ाया जाता है? ऐसे एम्स में तो पढ़ाते हैं. We teach like this in AIIMS, but I really doubt other colleges, do they teach like that? No, class देर तक नहीं चलनी है. Tell me what is the answer to this question. which of the following statement is true regarding the anatomy of the breast? So if you say superior and medial quadrant has more tissue, that is not correct. Superior and medial. It is superior and lateral which has more tissue. So superior and lateral, and as you say that, you will find that cancers are also more common. So glandular tissue, I am talking about glandular tissue. More tissue means basically mammary gland is a gland, so glandular tissue. There is more of glandular tissue on the upper and outer quadrant, not medial. So there are 10 lobules, not 10 lobules, there are 15 to 20 lobes, and in those 15 to 20 lobes, each lobe will have some 20 to 40 lobules. So I don't know exactly what was the question, but what was the option, but there are 10 lobules is not a perfect statement. What exactly, it doesn't make sense. In the mammary gland there are 15 to 20 lobes are there, and each lobe will have lobules. So each lobe can have 20 to 40 lobules, and cancers begin in the lobules. Cancer will start from the lobule, then it will involve the lobe, and then it will involve the entire mammary gland. So 10 lobule, you can say 20 to 40 is a good number, and I don't know whether this asks lobule or lobes. Axillary tail of Spence crosses the anterior axillary fold. There is anterior axillary fold which is the pectoralis major, and pectoralis major, from there is one opening to enter the axilla, and that is correct statement. The axillary armpit, the axillary tail of Spence crosses the anterior axillary fold, that is correct. Mammary gland has one extension into the axilla, and we call it as axillary tail of mammary gland, and to enter the axilla it will pass through the anterior axillary fold and then it goes there. So this is correct statement. If we are asking true, then that is the true statement. Nipple is located at the level of 4th intercostal space in most women. Now I don't know whether this choice was there or some other choice was there. Most women, if you say, though anatomically it is correct, anatomically you can say it is correct, but most women it is not at the 4th intercostal space. So it means you can say it is a correct statement, but it is not a very correct statement, because the level of nipple usually in most women it will be inferior. In fact, anatomically it is a correct statement, but in all these this is the most correct statement. If you read B.D. Chaucer-like books, they will say that D is perfectly fine, but if you say most women, then it doesn't fit well. So best is choice C. They have given lobes, okay, lobes, then if it is lobes, then 15 to 20 lobes, because I was wondering why lobules, lobes should be there. So 15 to 20 lobes, so 10 is not good number, you should increase 15 to 20 lobes. स्प्लीन इससे बड़ी थी तो T11 हो गया फिर, इसीलिए कह रहे हैं कि आपको एक अलग से, अच्छा ये जो अभी बच्चा यहाँ पे था LRR किया था जिसने, ये तो मैंने साफ साफ LRR में बताया था, कह रहे आपने पढ़ाया उसमें कुछ नहीं आया, एक बार जरा पीछे अभी YouTube में ही जाके देखो वापस LRR में मैंने क्या कहा था, और मैंने ये कहा था कि आप लोग मिस्टेक भी करते हो, इसी पॉइंट पे कहा था. सो मोस्ट कॉमन हर्निया इन फीमेल, अचानक तुम लिख दोगे फेमरल हर्निया, जो कि गलत है. अगर मेरा LRR नीट पीजी का देखो तो उसमें मैं ये बोलता हुआ नजर आऊंगा, जो कि गलत है. तो सही क्या है? सही ये है कि फेमरल हर्निया फीमेल्स में ज्यादा होता है, ये तो ठीक है, मोर कॉमन इन फीमेल्स, दैट इज देयर, लेकिन फीमेल्स में सबसे ज्यादा हर्निया कौन सा होता है, मेल हो फीमेल हो दोनों में ही, वो होता है इनडायरेक्ट इन्वाल्व हर्निया. सो मेल हो फीमेल हो दोनों में ही इनडायरेक्ट इन्वाल्व हर्निया सबसे ज्यादा कॉमन है. अब इनडायरेक्ट इन्वाल्व हर्निया किससे कॉमन है? डायरेक्ट इन्वाल्व हर्निया से, और वो किससे कॉमन है? फेमरल हर्निया से. ये है सीक्वेंस. स्टैटिस्टिक्स अगर आप देखो, इंडायरेक्ट इन्वॉल्व हर्निया मेल फीमेल का मतलब नहीं है, दोनों में ही indirect inguinal hernia is most common in male female, more common than direct inguinal hernia, and it is still more common than femoral hernia. Femoral hernia is very rare, it's very rare, but femoral hernia, if somebody is having, there are more chances that it is a female, because females have wider pelvis and the femoral canal is wider, and they have more chances of intestine or omentum moving into that. So this is your answer. आदर्श ने सही कहा, कुछ तो लोग कहेंगे, लोगों का काम है कहना. So even this is a repeat question, it is a repeat question. Lower lip paralysis after parotid ectomy, most likely injury to which nerve? Now be careful when you are talking about the facial nerve. Facial nerve will give branches, and in those branches there is one branch which is called cervical branch, and cervical branch is supplying platysma, and if you damage the cervical branch, platysma will be compromised and there will be problem with lower lip. You should know this. And problem with lower lip can also be there if you are damaging the marginal mandibular nerve. So marginal mandibular nerve, if it is damaged, again there will be a problem with lower lip. Remember, lower lip problem can be due to injury of marginal mandibular nerve and even injury of the cervical branch. Now if you say that when we are doing parotidectomy and we have damaged the marginal mandibular nerve, why there will be a problem with the lower lip? Because lower lip depressors, lower lip, the depressor levi inferioris, that will be compromised. What will happen if you damage the marginal mandibular nerve? If marginal mandibular nerve is damaged, the lower lip muscles like the depressor levi inferioris will be compromised and patient will have difficulty taking the lip down. Point 1. Point 2. What will happen if I damage the cervical branch? If you damage the cervical branch, platysma will be paralyzed, and remember, if platysma is paralyzed, again there will be lower lip movement problem. Lower lip can go into paralysis. Why? Because platysma also controls the movement of lower lip. Like, what is the job of platysma? Platysma is a muscle which is to express the expression of horror. Where is your lower lip going? What is the function of platysma? Where is your lower lip going? It's going down. It is also depressing the lower lip. And if you damage the cervical branch, lower lip depression gets compromised. So be careful. The examiners are very smart people. You cannot actually, they are very shrewd people, cunning people, and they know how to take out wrong answers from you. This is not a very difficult question as such, but still, lower lip paralysis after parotidectomy is injury to which structure? Best answer would be marginal mandibular nerve. But if marginal mandibular nerve is not given, still you have to mark your answer. Then it is cervical branch. And why? Because platysma paralyzed. Now somebody might say, if it is platysma which is paralyzed, how the platysma will compromise the lower lip? I told you. Platysma also is working for depressing the lower lip. If you paralyze the platysma, there will be some weakness of lower lip depression. I hope you got the point. Main trunk. Main trunk, if you damage, then all the muscles will be paralyzed. If you damage the main trunk, means here, then all the muscles will be paralyzed. You will have what is called Bell's palsy kind of feature. Entire half of the face will be compromised. Main trunk cannot be our answer. If marginal mandibular nerve is not there, then you take your answer as choice number D. Best answer will be marginal mandibular nerve if it is not available. And again, it is a repeat question. I remember I have discussed this question in previous year questions already. Parotid duct. If you damage parotid duct, it will not be affecting the lower lip paralysis. It will not be leading to lower lip paralysis. So parotid duct doesn't fit in at all. Okay, which of the following steps in thyroid surgery least likely to result in hoarseness of voice? The patient is having hoarseness of voice, means something wrong with recurrent laryngeal nerve, and recurrent laryngeal nerve also unilateral, because if it is bilateral recurrent laryngeal nerve, the patient will present with difficulty breathing. So unilateral recurrent laryngeal nerve problem, mostly that is what the examiner is asking. Which of the following in thyroid surgery least likely to result in hoarseness of voice? So there are chances that we might damage. What is this question? Which of the following steps in thyroid surgery least likely? Okay. So I think this should be the answer, because superior thyroid artery is running with the superior laryngeal nerve, which is a branch of internal laryngeal nerve, and if it is damaged, then there may be some problem with the voice, like cricothyroid muscle is compromised, and patient will have difficulty to tense the vocal cord. So that may happen. If the answer to this question should be choice A. Ligation of superior thyroid artery, when you are doing that, if you are not careful, you may damage superior laryngeal nerve, which is a branch of superior laryngeal nerve branch, which is internal laryngeal nerve, and cricothyroid muscle will be paralyzed, and there will be problem with the tension of the vocal cord. The pitch of the voice will be compromised, but it will not be hoarseness. Hoarseness comes if you have unilateral recurrent laryngeal nerve injury. If it was bilateral injury, then it will be respiratory distress. So unilateral recurrent laryngeal nerve lesions leading to hoarseness of voice could be anything like division of strap muscle. You have to divide the strap muscles, then only you will be reaching the thyroid gland. Maybe that time you have damaged the recurrent laryngeal nerve. Or removal of tubercle of Zucker-Kandel. What is this tubercle of Zucker-Kandel? Say this is the thyroid gland here, and posteromedially it is some thyroid tissue, posteromedially thyroid tissue, and that is where you have this Behr's triangle also. Behr's triangle means inferior thyroid artery, the common carotid artery, and the recurrent laryngeal nerve. They make the triangle. As I told you, I did not had much time to prepare the slides, so I am just trying to manage. I have good diagrams to discuss all this, but there was no time to put all those diagrams, because yesterday there was exam, today they are telling discuss, and I haven't slept for even a single second. I haven't slept for last 32 hours, not even a single blink of eye. So if you are working on a tubercle of Zucker-Kandel, which I had a diagram which is there in my computer, could not put it on the PowerPoint. So that is posteromedial projection of the thyroid gland. You may be damaging the recurrent laryngeal nerve, because recurrent laryngeal nerve is of course coming this way. It is coming this way, and it has to supply some of the muscles, and that is where you have this triangle also, Behr's triangle. Inferior thyroid artery, common carotid artery, and recurrent laryngeal nerve, they make a triangle. Again, well seen in the diagram, which I again to tell you, due to shortage of time, I could not put it, but best answer is choice A. Then this ischial spine. Now, this is a controversial question. Ischial spine. What do you think is the answer? Now the problem is I have all the diagrams in my computer somehow, and let me see. Actually I tried to sync it. Let me see if it has come. Because my computer syncs from there to here, So maybe I am having, after some time it will appear on this computer also. May 24. Let us hope that it has appeared. Yeah, very good. Dr. Nikita. Dr. Nikita. Dr. Nikita was teaching this. And what I do is, I watch all the faculty, what they are doing, what they are teaching, and I learn from them also. You know, you ask me a question about cerebellum and this midbrain, I borrowed the information from Dr. Nikita. I have seen other faculty, medicine, surgery, pediatrics, ENT, orthopedics, anesthesia, whoever has taught you in the last 24 hours, I have watched all the videos. That is why I did not sleep, because I don't want any stone to be left unturned. When I come in front of you, I should be ready. But if you don't give me time, how can I be ready? So this is Dr. Nikita anyway. Thanks to her, because she gave me 3-4 things which I could discuss. But now let us look at that thing. Ischial spine. Yes, very good. Yes, yes. Now you tell me the details. I was hoping that this would have synced, and it has synced. So it is good thing. Now, as you see, copy. Anyway, it will not let me work the way I want. So as you look from the front, see, this is the level of ischial spine. This is the level of ischial spine. This is the level of ischial spine, and that is the sacrum here. This is the sacrum, sacral hiatus sacrum. So if this is the sacrum, sacral hiatus sacrum, then I think the answer should be S345. You are looking from posterior view. This is posterior view, the buttock region, the lower back region. Lower back region, you know, the highest point of iliac crest is the highest point of iliac crest is where you put the lumbar puncture needle, L45. L45 level, highest point of iliac crest, Taffier's line. So that is L45 vertebra. This is posterior superior iliac spine, S2 vertebra. So posterior superior iliac spine, S2 vertebra. If you say ischial spine, then it must be S345. S345. Now, it is a controversial question. Why? I'll show you a diagram now. So if it is highest point of iliac crest is L4 vertebra, the gap between L4 5, that is where you do lumbar puncture for spinal tap or spinal anesthesia. If it is posterior superior iliac spine, that is the S2 vertebra, which the examiner gave you in the option. And this is the sacral hiatus where you do, you know, sacral anesthesia when you give sacral hiatus through there you will enter. And this is the level of ischial, this is ischial, this is the trochanter, this is the trochanter level. So if you look at this way, then it is S345. But I have one more diagram. Even here you can see what I am telling you, that what is ischial spine basically? Ischial spine is separating the greater sciatic notch. Ischial spine is separating the greater sciatic notch from the lesser sciatic notch. The greater sciatic notch from the lesser sciatic notch. So this is ischial spine. Now if that is the ischial spine, can you see ischial spine is at which level? Sacral 345 you can say. Sacral 345. But I am not very sure about this answer, because now you will see this, and this is why, that is why it is a controversial topic. If you follow Nikita madam, if you follow Nikita madam, she is telling, which is correct, tip of the coccyx and going to greater trochanter, that is where you have ischial spine. This is ischial spine. Again, you know, ischial spine is the one which is separating greater sciatic notch and lesser sciatic notch. This is greater sciatic notch, lesser sciatic notch, and this is the ischial spine. And if this is the ischial spine, then you can see it is at the tip of the coccyx, tip of the coccyx, because coccyx is bent. So you put a straight line from tip of coccyx to greater trochanter, and ischial spine comes in that level. So what is your answer then? If that is the information, what is your answer? So you have two answers basically, but in those two answers also, which one will you take? So I'll prefer my answer, I'll go with Dr. Nikita. She's a radiologist, I am an anatomist. I'll go with the tip of the coccyx. B is better answer than A. Both are answers. B is better answer than A. Both are answers. B is more precise and A is less precise. वेगस एक्सरी कॉम्प्लेक्स और फ्रेंजियल प्लेक्सस तो बाद में करेंगे भाई, अभी क्लास के बीच में ये मत लेके आओ। अभी तो जो आज का काम है वो तो करने दो। ये भी एक क्वेश्चन था। चलो anyway, I think we have managed. So these are the questions which we have taken care of. I'm just going revising. So this was the question and we already gave the answer. Answer will be choice number C because they are marking the zona glomerulosa. Then we had this question. It was asking for zone of calcification, and zone of calcification we have marked as the choice number C. This is the zone of calcification. Then we had this question. It was thoracic vertebra. Which joint is not there? So we have marked it as the synchondrosis because there is no primary cartilaginous joint here. And then this question, it was asking second order neuron in the spinal sensory nucleus, and we have marked it as the pain. Choice number B is the answer. Then this question, substantia nigra connected to basal ganglia, that, but you told that this was not the question. So if it was this question which I told you I borrowed from Dr. Nikita, this diagram I took from her, that the cerebellum diagram was there, dentate nucleus, and midbrain diagram was there with red nucleus. So maybe they are asking about dentato-rubro-thalamic tract. So maybe that was the question. And if it was the same question which I showed, then striatum should be the answer. Nigrostriatal pathway. Nigrostriatal pathway which can be compromised in Parkinson's disease. Then this question was there, not present at the floor of inferior horn of the lateral ventricle. Then we answered it as the tail of caudate nucleus because it is at the roof of the inferior horn of the lateral ventricle. And this was the question. It was asking about the structure passing between superior middle pharyngeal constrictor. It is the structures belonging to third arch. So structures which belong to third arch are glossopharyngeal nerve supplying stylopharyngeus muscle. There is only one muscle which develops in third arch, and that is stylopharyngeus, and the nerve of third arch is glossopharyngeal. So both of them pass in this gap. So this was one way we did the things. The other way was we were talking about these diagrams, and according to my thinking, let us try to do it this way. So T10 level, because I told liver is there, spleen is there, lungs are there, so T10. But as you told, maybe it was not T10, it was T11, 12. We will discuss later. Then interventricular septum, so it was the anti-interventricular artery which supply most of the interventricular septum, especially anterior 2/3 of the septum. So A will be the answer. And if you look at this, it depends whether arrow was here or here. So if it is horizontal and reaching the midline, it is posterior end, and if it is more oblique and anterior end is missing because costal cartilage doesn't appear on X-ray. But here I believe answer was anterior end. In this question, asking true statement regarding the anatomy of breast, the true statement will be axillary tail of Spence crossing the anterior-axillary fold to reach the axilla. Otherwise, 10 lobes, no, 15 to 20 lobes. And superior medial quadrant is more tissue, no, it is upper and lateral, superior lateral which has more tissue. That is where you have axillary tail of Spence also so much that it enters the axilla itself. Superior lateral is more bulky, more glandular. And nipple, this is okay statement, but it is controversial because if you say most women, then it is at a lower level. And most common hernia in female, male doesn't matter. Indirect inguinal hernia more than direct inguinal hernia, and femoral hernia is very rare. If there is a femoral hernia, think more of a female. But don't say that females most commonly they have femoral hernia. That is wrong. Most commonly they have indirect inguinal hernia. That is why answer is C. Lower lip paralysis, best answer marginal mandibular nerve if not found. Cervical because of the paralysis of platysma, which also help in lowering the lower lip. And then thyroid surgery, if you are telling it is hoarseness, it is unilateral rectolaryngeal nerve injury. But if you talk about choice A, it is compromising the cricothyroid muscle, interlaryngeal nerve, branch of supralaryngeal nerve. So tensing of the vocal cord will be a problem. Pitch of voice will be compromised, not hoarseness. Otherwise, during any of these activities, you may damage the rectolaryngeal nerve. Ischial spine corresponds to which level? We already have mentioned that it should be the tip of coccyx. If not found, you can take your answer as choice number A. ओके हाँ ठीक है अनुज, अब तो आराम ही करेंगे। पर एक बात बताओ, जब एग्जाम हो जाता है उसके बाद नींद आती है? जब एग्जाम हो जाता है उसके बाद नींद आती है? इतना ज़्यादा हाइपर हो जाता है ब्रेन कि उसको नींद आने में भी वक्त लगता है, नींद ही नहीं आती, आएगी नहीं। S345 नहीं था तो क्या था? विंसेंट गॉग, It was S3 only. तो ठीक है, फिर तो टिप ऑफ कॉक्सिक्स आंसर है ही है, फिर तो टिप ऑफ कॉक्सिक्स आंसर है ही है। मुझे आप लोगों से केवल एक चीज चाहिए है, और वो क्या है? आप अच्छे डॉक्टर बनना, चाहे फिजिशियन बनो चाहे सर्जन बनो, और एनाटॉमी अगर अच्छी होगी, जो कि मैं करके ही मानूंगा, तो आप अच्छे डॉक्टर अपने आप ही बन जाओगे। Okay, I think we have taken quite good number of questions, though I am not very satisfied because I was not prepared. 50% I was prepared, but eventually we'll be making an LRR session, and there I'll discuss all these questions in great detail. Okay, and let us just hope that whatever you did, it was good enough, because you are in the same boat. Everybody was in the same boat. If you made mistakes, your competitors would also have made mistake. So let us hope that you yourself succeed, and there is no need of going into NEET PG at all, because you already got good rank in INI-CET, and you are somewhere at AIIMS Delhi or PGI Chandigarh or NIMHANS or JIPMER. My best wishes are with you. Live long and prosper. Okay, so have a nice evening. Take care. Bye. AIIMS Jodhpur also. Yes. My best wishes.